other day, I had this scenario up. You're the SRNA, you're the rRNA. Patient presents for elective shoulder surgery. It's going to be a long case. Patient took their Cialis last night. What are you thinking? What's going on? And I just got to say, somebody's answer, I freaking love it. Cancelectomy because I'm not pushing Neo this whole case. Ding, 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 ding. Love that. Okay. But let's talk about why. Let's break this down. So first of all, this is your patient. I love my stick figures. I use them all the time in my coaching program. So you have your patient here, right? They're on Cialis. You can also say Viagra, right? I believe the difference is like the half-life of how long it takes for them to get out of your system. Okay. So this is your patient. What are these two drugs? Essentially, they are PDEIs, phosphodiesterase inhibitors. Milrinone is one of them too. There is like a whole family of PDEIs. This happens to be PDI5. Okay. PDE5 helps regulate vasomotor tone, blood pressure, and helps with treating hypertension, pulmonary hypertension, and erectile dysfunction. Okay. So when you have a PDEI, a phosphodiesterase inhibitor, when it's inhibiting phosphodiesterase, what happens is it increases the second messenger, cyclic GMP, cyclic guanosine monophosphate. Okay. It increases that. And then at the cellular level, when you increase CGMP, you are going to get smooth muscle relaxation and also pulmonary relaxation of the pulmonary vasculature. Okay. So that's specifically what PDEI5s are going to do. All right. Now, so you can treat one of two things. Okay. Side note also, patients that are on Cialis or Viagra, you do not want to give them any nitrates because nitric oxide, right? That's how nitrates work via the nitric oxide pathways. They can also stimulate, nitric oxide can also stimulate the production of CGMP, causing more vasodilation. So your nitroglycerin, your isosorbides, things like that. So you don't want to put those concurrently together with patients that are on those. Okay. Or give them to them if you're providing the care, right? Depending on when the last time they took it, okay? So your patient decided to live their best life the night before their shoulder surgery and did not stop taking their drug. In fact, they took it, all right, within this 12-hour window, not even that, right? So this is what's going on. And this is essentially how you're going to be thinking about all the things. You're going to be thinking about your patient's comorbidities, right? Their health. You're going to be thinking about the medications they're on, and then you're going to be thinking about the interplay of all the factors when you are giving them anesthesia. Okay. This is the job. And this is why we have to have such a deep knowledge level of drugs and of patient's pathophysiology in their body, right? All of that cellular level. That's why it's super important. That's why you have to drink from the fire hose of all the info in school, right? That's what it is. Okay. So let's look at all the factors as to why this might not be a fun time for you as the anesthesia provider. So number one, they have shoulder surgery. Number one, they're going to be in sitting position, okay? When you are in sitting position, under anesthesia especially, your MAP is going to drop, your CVP is going to drop, your stroke volume and cardiac output is going to drop, and your cerebral perfusion pressure, can't even talk, cerebral perfusion pressure is also going to drop, okay? So that's going to be happening when you are in the sitting position, okay? Also, when you are laying supine, right? So sound like I'm laying down and you're taking my blood pressure and I'm all supine and I'm laying down. Okay. You're basically the arm and your brain, they're kind of at the same level, right? Like your blood pressure is what your blood pressure is when you're laying down. Okay. When you're sitting up, there is a hydrostatic gradient now. Okay. Because your brain is up here, your arm is down here, you're sitting up. Okay. So your blood pressure in your brain is going to be less than what you are reading in your heart and in your arm near your heart, right? Because you are now sitting upright. It's a hydrostatic gradient. There's a blood pressure difference from your arm, your heart, up to your head. All right. And I believe it's about a 0.77 millimeter of mercury decrease for every centimeter gradient you are up. Okay. So essentially, the approximate distance between your brain and the side of your blood pressure cuff when you are sitting, it's going to be about a 10 to 30 centimeter kind of difference. Okay. So your MAP in your brain is going to be 8 to 24 millimeters of mercury lower. All right. So just because this is saying 120 does not mean that's what's going on in the brain because of that hydrostatic gradient. Okay. So there's a couple things for being in the sitting position that are going to cause some possible hypotension and some brain hypotension. People have had strokes during shoulder surgery because there has not been enough blood flow to the brain. Okay. Number two, your anesthetics. What do anesthetics do? They vasodilate. That's what they do. Your Sevo, your ISO, your DES, your propofol, right? They are all vasodilatory, causing usually hypotension, especially at induction when you're putting the patient to sleep, you're loading them up, you're getting them to sleep, you're getting on the gases, you're positioning them, all the things, right? Hypotension because we are vasodilating them with our anesthetic drugs, okay? Plus, positive pressure ventilation, right? Positive pressure ventilation, you're putting positive pressure into the intrathoracic cavity, also can cause a decrease in cardiac output, okay? So it's another like little one and not like a huge issue, but just something to think about. What are the mechanics of positive pressure ventilation? How are they going to interplay with everything, right? Last but not least, interscaling nerve block, right? So you do an interscaling nerve block. Okay, fine, no problem, right? We'll nerve block them, okay. But then we're going to block them and then we're going to sit them up. There's this little reflex called the Bizold-Jarisch reflex, okay? It's kind of like a form of vasovagal syncope. And essentially, once again, when you're sitting up, you get this venous pooling, right? Because you're sitting up, you're vasodilated, you've got this venous pooling going on, you got this beautiful blocks, you're not even feeling any pain, you're just living your best life under anesthesia, right? And what happens is it heightens, it kind of irritates your left ventricle, right? And then you get this reflex arterial vasodilation, and then you get this vaguely mediated bradycardia, right? And then you get hypotension, all right? So this is what you have to be thinking about when your patients are presenting with certain medications. And it's always, guys, there is no clear-cut perfectly answer of do we cancel, do we this, right? There's always things to take into account. Do they have to have the surgery? Is this an emergency? Like what's going, right? There's so many things interplay that are going on, but this is how you are thinking. And then you have to be able to come to a decision that you feel is best. Okay. So I hope that was super helpful. If you guys have anything else to share, let me know, but this is essentially that. And I believe I wasn't a part of this, but I believe this case was like nix, because at the end of the day, elective surgery isn't really worth it to struggle, right? Would you, if it was your family member, if it was your dad, if it was your grandpa, if it was your parent, if it was your friend, if it was your husband, friend, partner, whatever, would you want to take this risks? Always be thinking about that when you make your decisions, okay? Happy anesthesia, guys.